Malignant hyperthermia is a genetic disorder of skeletal muscle that, when triggered, can result in extreme hypermetabolism, injury, and death. The causative factor occurs within muscle cells. The normal intracellular process associated with muscle contraction begins with calcium release from the sarcoplasmic reticulum. Calcium interacts with muscle fibers, specifically the troponin-tropomyosin complex, to initiate contraction. After muscle contraction has occurred, muscle fibers relax as calcium re-enters or is sequestered back into the sarcoplasmic reticulum. In malignant hyperthermia, the physiologic aberration occurs as ryanodine receptors, which are present on the sarcoplasmic reticulum, become sensitized and allow for the continual release of large amounts of calcium. The result is continuous full-body muscle contractions. The need for cellular energy is increased during muscle contraction. Oxygen and glycogen are used in great quantities by mitochondria to produce ATP. However, the metabolic byproduct is carbon dioxide and lactate. Heat is produced as ATP is utilized by muscles to fuel the process of contraction. This process is dramatically increased during an episode of MH. An episode of malignant hyperthermia can occur in people who are MH susceptible from physiologic stress alone, but this is a rare event. In anesthesia, all of the inhalation agents and succinylcholine have been implicated as triggering agents and therefore are absolutely contraindicated in persons confirmed or suspected of having MH. The signs and symptoms associated with malignant hyperthermia are the result of hypermetabolism from sustained skeletal muscle contraction and include increased heart rate. This is most often the first sign, however, it is a nonspecific sign. Rise in end-tidal CO2, the most reliable sign. Decreased oxygen saturation, increased temperature, muscle rigidity and masseter muscle rigidity, arrhythmias, myoglobinuria, hyperkalemia, and mottled cyanotic skin. All episodes of MH are potentially life-threatening. The signs and symptoms associated with MH exist on a continuum of severity from mild to severe. Also, the onset is variable and can be rapid or begin within 24 hours after anesthesia. These differences in the clinical presentation are dependent on the concentration of intracellular calcium. The Malignant Hyperthermia Association of the United States is a free service where any practitioner can be in contact with an expert at diagnosis and treatment of MH. Prompt identification and treatment of this crisis is essential. Mortality is increased by 8% with each 15-minute delay in treatment of MH. Treatment includes calling for help and the malignant hyperthermia cart, stopping all triggering agents, hyperventilating with 100% FiO2, administering Dantrolene, calling the MH hotline and communicating with the surgical team, cooling the patient and treating metabolic acidosis, hyperkalemia, and dysrhythmias as needed. Labs should be sent and a Foley catheter placed. Dantrolene sodium is the definitive antidote to reverse the physiologic effects of MH. The proposed mechanism of action includes desensitization of ryanodine receptor activity and decreasing the release of calcium from the sarcoplasmic reticulum. Since dantrolene is lipid-soluble, calculation of the dose of dantrolene should be based on the patient's actual body weight. Dantrolene must be reconstituted with sterile water to avoid precipitation. Each dantrolene vial contains 20 milligrams and should be mixed with 50 milliliters of sterile water. The loading dose of dantrolene is 2.5 milligrams per kilogram. So for a 70 kilogram patient, 175 milligrams is needed. That equates to 9 vials. The effects associated with dantrolene begin within 6 minutes. Most episodes of MH are treated with a total dose of dantrolene between 2.5 and 6 milligrams per kilogram. A new preparation of dantrolene sodium named Ryanodex has been FDA approved for treating MH. Since the concentration of Ryanodex is 250 milligrams per vial, rapid reconstitution and administration can occur.